Good morning, everyone. Thank you for joining us today to discuss CMS resources related to the National Correct Coding Initiative, or NCCI. My name is Karen Curtis, and I am a Provider Outreach and Education Specialist here at WPS. Today, I am joined by my teammate, Ashley Dakota. Ashley is going to be helping me out today by monitoring the chat for questions that you may have and providing some additional information during the presentation. I have just a couple of things to cover before we get started. First, if you haven't downloaded a copy of today's presentation and would like to, there is still time. A copy can be found on our live events page, which is located within the WPS Training Center. In our list of upcoming events, there's a column titled Materials. This is where you can find a link to the PowerPoint material, and I will also have Ashley add a link into the chat to get you there quickly. Our training center also contains a web page for Encore presentations. All of our webinars are recorded, and if there's no technical issues, we will put the recordings on our web page. Videos are available for up to 90 days and can be watched on our webpage without you having to go to YouTube. We know that some of you may not be able to access YouTube from your company computer, and we want to make sure that you're able to receive the education that you're interested in. Recordings of our webinar can also be found on our YouTube channel, where they will remain until the webinar is redone or if information has changed. Later, there will be a question and answer session if time permits. If you have any questions related to today's topic, please send those using the chat feature. I did receive some pre-submitted questions, which I will answer at that time. Now, if there's any questions that I don't get to, or if some maybe require some additional research, then I'm going to send out an email and I'll provide those answers, and it will go to everybody that's in attendance today. So I just want to make sure that regardless of time, we will get your questions answered. Our goal is to provide you with an excellent customer experience. We want to know how we're doing, so later in the presentation, you will be given the opportunity to provide feedback on today's event. This is your chance to let us know what we're doing right, and let us know if you feel that there's areas where we can improve. It also allows you to give us input on what types of education you'd like to see in the future. And while this is a CMS survey, WPS does look at our results, and we do our best to make the improvements that you ask for. Now, here at WPS, we do our best to provide you with accurate, up-to-date education. If you've worked in Medicare for a while, you know that Medicare rules and regulations can change. So for this reason, the CMS website should be checked for updates, and federal regulations will take priority over anything presented today. Lastly, I need to let you know that CMS does prohibit the recording of this webinar. We are recording this event so it can be posted as an Encore presentation. The recording will be available next week if you'd like to review or share any of the material being presented today. My goal today is to provide information and resources that will help you understand and use the NCCI tools. To do this, I will provide some general information regarding NCCI. We'll discuss the different edits and modifiers that can be used. And lastly, we'll take a look at the NCCI webpage and the tools provided by CMS. This is the American Medical Association copyright notice for CPT codes. During this presentation, I cover information that contains CPT codes. So this notice just lets you know that Medicare does not own the codes or their descriptions. So let's get started today with an introduction to NCCI. The Centers for Medicare and Medicaid Services developed the National Correct Coding Initiative, or NCCI program, to promote correct coding methodologies. Their hopes are to control incorrect coding, which leads to improper payments. The coding policies used are based on coding conventions that can be found in the American Medical Association's current procedural terminology professional code book, the national and local Medicare policies and edits, coding guidelines that are developed by national societies, standard medical and surgical practice, and current coding practices. The NCCI program was originally developed for Part B claims that were billed on a CMS 1500. But in 2000, many of the edits were added to the outpatient code editor to process Part B outpatient hospital services. In 2006, therapy claims from most sites were also included. So now, instead of just having physicians and hospitals, therapy claims from skilled nursing facilities, comprehensive outpatient rehabilitation facilities, and outpatient rehabilitation agencies are also included. These edits are meant to apply to services billed by a single provider or supplier for a single patient on the same date of service, and it affects all Medicare contractors. These edits do not include every possible combination of codes or types of unbundling, so providers and suppliers have a responsibility to make sure that they are coding correctly even when an edit does not exist. So the National Correct Coding Initiative is broken down into 3 types of edits. There's procedure to procedure, medically unlikely edits, and add-on codes. Procedure to procedure edits are automated prepayment edits that are developed to prevent inappropriate payment of services that should not be reported together. Medically unlikely edits, or MUEs, are used to reduce improper payments for Part B claims. These edits set a limit on the number of units of service that can be billed for a specific HCPC or CPT on a single claim. Lastly, are add-on code edits. An add-on code is a secondary code that describes an additional service performed in conjunction with the primary service. These edits ensure that add-on codes are only billed along with their primary procedure. The NCCI program is updated quarterly with new versions implemented January 1st, April 1st, July 1st, and October 1st of each year. Changes in the program can come from 3 sources. First, we have coding changes. This relates to additions, deletions, or modifications made to CPTs, HCPC Level 2 codes, or the CPT Professional Codebook instructions. CMS policy initiatives can affect the edits in a variety of different ways. For example, burden reduction initiatives might lead to fewer or less complex edits. On the other hand, initiatives to reduce fraud and abuse could result in more restrictive edits in order to prevent improper coding and payments. CMS also takes into consideration comments made by the medical associations and healthcare organizations, medical directors and staff from the MACs, as well as providers, suppliers, and billing consultants. After making the proposed changes, CMS will contact the American Medical Association, National Medical and Surgical Societies, non-governmental organizations, as well as providers and suppliers. And these groups will participate in a review and comment period. Now, although they usually agree with the changes, they are allowed to make comments which CMS will take into consideration. CMS has also created a process for those who would like to request a review of a procedure-to-procedure MUE or add-on edit. Written requests should be sent to the email address you see listed here on this slide. The request should include a rationale for reconsideration, as well as a suggestion of the changes that you would like to see. Requests should not include any protected health information or personally identifiable information. Now, any request that is received that contains PHI or PII will be automatically discarded. If you have claim-specific questions, those will need to be addressed by the MAC who processed the claim. So for WPS, you would want to contact our customer service department. They would be able to access the claim, and they can provide answers to questions based on how the claim processed. So now let's get into some detail of the actual edits. We're going to begin with procedure to procedure, or PTP edits. The goal of these edits is to prevent improper payments by ensuring that Medicare is not paying for services that are bundled or should not be reported together. Understanding the principles allows providers to avoid coding errors and potential denials. Procedure to procedure edits also reduce administrative burden. I had mentioned earlier that these are automated prepaid edits, so it reduces the need for manual reviews and appeals. The edits are broken down into two tables. There's hospital and practitioner. The hospital PTP edits apply to the types of bills that are subject to the outpatient code editor. This includes outpatient hospital services, therapy providers such as skilled nursing facilities and rehabilitation facilities, as well as certain home health agencies. Practitioner edits apply to physicians as well as ambulatory surgical center claims. PTP edits look at pairs of HCPCS and CPT codes that should not be reported together for reasons such as being mutually exclusive or part of a larger procedure. Now, there may be times when it is clinically appropriate to bill the two codes together. And when that occurs, you'll want to include the appropriate NCCI associated modifier. You'll also want to make sure that the documentation is within the patient's medical records. That's one thing that I've seen throughout the NCCI is that you're always going to want to have documentation to support whatever coding decisions you make. The files have been broken down into 4 different zip files based on HCPCS or CPT codes, so it's not as cumbersome as it could be. You'll just want to make sure that you're downloading the correct file based on the codes you're looking for. Many of these edits have been incorporated into the outpatient code editor. So the IOCE quarterly release files is an additional resource that could be used to get more information on specific edits. I know that's something that I've used in the past when I'll get a denial, like a FIS reason code, and I don't understand what exactly the system is looking for. I have looked at the IOCE quarterly release files to get some additional information, and sometimes it really does help. Now here I've included a portion of the procedure to procedure code pair tables. We'll take a closer look in just a minute, but I wanted to at least introduce it here. So each spreadsheet has a column A and B. If a provider reports the 2 codes for the same beneficiary on the same date of service, column A is going to be eligible for payment and column B is denied unless an appropriate modifier is allowed and present on the claim. Well, the next column is the edit status prior to 1996. You may be wondering why anyone would care about the status of an edit prior to 1996. And it probably doesn't matter to most of us, but 1996 was the year the NCCI program was officially implemented. So this column helps keep track of edits that were already in place prior to the program's existence. Column D shows the edit's effective date in a year, month, and day format. Column E is in case there's a deletion date. This is also going to be in a year, month, and day format. Column F is going to let you know if a modifier may be appropriate. So this column will contain one of 3 values. A 0 lets you know that there are not any modifiers associated with NCCI that will allow you to use this code pair. When no modifiers are allowed, only the code listed in column A will be payable. If there's a number 1, this means that a modifier can be used with the code pair when appropriate. Then the last option is number 9, and this appears with code pairs that have a deletion date that is the same as their effective date. The last column, or column G, provides the category that gives the rationale for the edit. So in the example here, you see a lot of misuse of column 2 code with column 1 code. CMS uses this to describe a group of codes that should not be reported together. Now, this isn't to say that these codes can never be billed together, but there may be limited circumstances where a modifier would be allowed. You can also see CPT manual or CMS manual coding instructions. This means that you can find coding instructions in either the CPT manual or a CMS manual. Another rationale can include standards of medical surgical practice and mutually exclusive procedures, among others. Now, earlier I did download a copy. This is from the actual hospital. So again, we have the first code, which would be the payable code, the second code, which would only be allowed if a modifier is allowed. We have the effective date, and here you can see, let's just take an example of this. This does have a lot of codes that can be billed with it. So these codes would be allowed if you had the appropriate modifier on the claim. It also gives you the rationale behind it. Let's go back. Now, MUE edits are another tool that is used to reduce improper payments. Medically unlikely edits are a type of edit used to identify and potentially deny claims with an unusually higher number of units of service for a specific HCPC or CPT code. MUEs establish a maximum number of units of service that is expected for a given code on a single date of service for a single patient. Now, while most of the MUEs are published by CMS, there are others that are considered to be confidential. If an MUE is determined to be confidential, then the values are not going to be released. Now, an MUE status is something that can change, so just because the value is confidential now does not mean that it won't be published at a future date. The MUEs are also split into 3 downloadable files. This includes tables for DME supplier services, facility outpatient hospital, and practitioner services. Now here you see an example of the practitioner services MUE spreadsheet. Column A contains the HCPC or CPT code. Column B is titled Practitioner Service MUE Values because we're looking at the Practitioner Services edits. This column shows the maximum unit of service that can be reported for this code under most circumstances for a single patient on a single date of service. Column C is for the MUE adjudication indicator. Now here you're going to see a value of 1, 2, or 3. An MUA adjudication indicator determines how a claim line is processed based on the MUE value assigned to a CPT or a HCPC code. A value of 1 means that it's a claim line edit. Now, if the unit of service on the claim exceeds the MUE value, then the line's going to deny. Modifiers can be used to allow for reporting of medical necessary units of service which exceed the MUE. An MAI of 2 means that the edit is an absolute date of service edit based on policy, regulation, or published guidance. Exceeding the MUE value will result in a denial, and these denials generally are not appealable because they are based on fixed policies. You also will not be able to submit an adjustment on these claims to add a modifier. Lastly is an MAI of 3. This is a date of service edit based on clinical benchmarks. So if a claim is denied due to exceeding the MUE values, the denial can be appealed. Medical records can be provided to show medical necessity for the excess unit of service. Well, the final column is to explain the rationale for the MUE. Again, you can see rationales like we did for the procedure to procedure edits that state that there is a policy or instruction related to appropriate codes or appropriate units for the code. This may be anatomic considerations. For example, the human body only has one appendix, so an appendectomy is only going to have a value of 1. Prescribing information is based on FDA labeling as well as off-label information published in a CMS-approved drug reference book. Again, I did download one of the MUEs. This one you can see it has outpatient hospital services MUEs. So these would be the units of service that would be allowed on hospital outpatient claim. Again, here's the adjudication indicator. So there are a lot of 3s in here. So again, if it's a 3, then it's a clinical benchmark, and if it's denied, it can be appealed. So that's something that you'll really want to pay attention to also, is this MUE adjudication indicator, so you know what correction action that you can take on your claim if you receive a denial. The last group of edits that we're going to discuss today is the add-on code edits. Now, an add-on code is a HCPC or a CPT code that describes a service that is performed in conjunction with a primary service by the same practitioner. Add-on codes are rarely eligible for payment when reported without the primary procedure code. These codes are categorized into 3 types based on how they are associated with the primary procedure code. So you have type 1, which has a limited number of identifiable primary procedure codes. In this case, all acceptable primary codes are defined in the CPT Professional Code Book or in the HCPC files. In general, type 1 add-on codes are eligible for payment if one of the listed primary procedure codes is also eligible for payment to the same practitioner for the same patient on the same date of service. A type 2 add-on code does not have a specific list of primary procedure codes. For those, the MACs are encouraged to develop their own list of primary procedure codes. For type 3, some, but not all, primary procedure codes are identified in the CPT manual. MACs are advised that these lists are not all-inclusive, and there are other acceptable primary procedure codes. Like type 1 and 2, a type 3 add-on code is eligible for payment if an acceptable primary procedure code is also eligible for payment to the same practitioner for the same patient on the same date of service. CMS will update the list of add-on codes on or by January 1st. This is going to be based on changes made to the CPT or HCPC Level 2 manuals. Quarterly updates may be posted if additional updates are made. Here is a sample of the add-on code edit spreadsheet. The first column lets you know if the code is a type 1, 2, or 3. The second column lists the add-on code. Next is for the deleted date, if applicable. Primary codes are listed, and there's a comment for a deletion date for those as well. Then we have the effective and deleted date for the add-on code edit. Finally, there is a column for special instruction notes. So as you can kind of look at this for the type 2, those are one where CMS has not listed a primary procedure code, and the MACs are encouraged to develop their own. So you can see over the special instruction notes, it does say contractor defined primary codes, and it doesn't list anything specific. I will also tell you that the add-on code spreadsheet uses a Julian date instead of the year, month, and day format that's used on the other two spreadsheets. So when you kind of look at the dates, it looks a little off. You're trying to figure out what they're trying to put there, but it is the Julian date. So you have a little extra figuring to do on that side. I did also download the latest copy of the add-on code spreadsheet. So you can see this has a C, and that's because the primary code is to be determined by the MAC. But most of them, as we scroll down, are type 1s, so they will have specific codes listed for them. So now that we've discussed the different edits, let's talk about what happens if the system denies your service. First, we need to remember that these are coding denials. They are not medical necessary denials. The edits are created based on whether procedures can be billed together, maximum units of service, and if a code should be billed along with the primary code. These services are denied provider liable. Again, this is a coding error, so you should not bill the patient, and issuing an advanced beneficiary notice in these situations would not be appropriate. CMS has also stated in their information that if an ABN is issued, it will not switch liability to the patient. Now, appeals can be submitted. If it is determined that the claim was coded correctly, then the initial determination will stand. If it is determined that a modifier would have been appropriate, then the reviewer may change the initial determination. So what action can be taken? First, check your claim and make sure that everything was actually coded correctly. Was a modifier allowed, and would it be appropriate given the situation? Remember that documentation must support the use of a modifier if it is going to be added to a claim. Now, if you determine that a modifier should have been added and you bill using the multi-carrier system, so in other words, that's you submit claims on a CMS 1500 or 837P, then you can resubmit a claim for the denied services only and add the modifier. Another option would be to request a clerical reopening to add, change, or delete a modifier. The most efficient way to do this would be to use the portal, but it can also be done by phone, fax, or mail. If you bill on a UB04 or 837I using the fiscal intermediary shared system, depending on the exact FIS reason code, you may be able to perform an adjustment in order to add the modifier to the services. Again, documentation must support the use of a modifier. Lastly, you can request a redetermination if appropriate. Services that can be appealed will have a remark code MA01 on the remittance advice, and there's going to be a statement that says, if you do not agree with what we have approved for the service, you may appeal your decision. So we've mentioned that modifiers can be added if appropriate, but we haven't really discussed them. So let's take a look and talk about the options. Modifiers should only be used to your claim if the clinical circumstances justify using them and your documentation supports the decision. They can be used to provide additional information regarding the billing situation, Modifiers can explain that procedures were performed at different anatomical sites. Maybe a laboratory test had to be repeated, or maybe you're billing for a separate procedure or encounter. It is important to remember that not all modifiers can be applied to the NCCI scenarios, but proper use will allow the claim to bypass edits. Again, it's never appropriate to add a modifier to a claim if the sole purpose is to bypass an edit. Now, different modifiers are appropriate for different situations. There are anatomic modifiers. So these may be used if a pair of codes are possibly subject to the procedure-to-procedure edits, but they were performed on different body parts. Examples would be RT and LT, which identify the right and left side of the body. There are modifiers that identify specific digits on the hand and feet. There's even modifiers that distinguish which eyelid a service is being performed on. Global surgery modifiers are used to indicate specific situations within the global period of a surgical procedure. They can clarify if a service is being performed as preoperative, intraoperative, or postoperative. Other modifiers can report that a procedure or service was distinct or independent from another service that was performed on the same day. One of the examples given during the registration process was that two procedures on the same anatomical site, such as the elbow, but it was two different incisions with two different procedure CPT codes. So in this case, first you would need to look at the procedure-to-procedure edits to determine if the codes are paired, and if they are paired, then you would need to determine if a modifier is allowed. If yes, then you could move forward to finding the appropriate modifier that fits your specific situation. Modifiers can also show that there's a separate encounter with a patient on the same date of service. Maybe a service was performed by a different practitioner or on a separate organ or structure. Now we are going to go take a look, but there are quite a few resources for the NCCI tables and the use of modifiers. I've included some that I think would be helpful for you. First, I wanted to show you where you can find the NCCI webpage on the CMS website. You'll start at the cms.gov. You'll select Medicare, Coding and Billing, and then in the left column, you're going to find National Correct Coding Initiatives NCCI Edits. Once you get to the NCCI webpage, then the column on the left is going to contain links to the specific edit web pages. There's manuals for resources. There's also an FAQ that you might find helpful. There's also links that will take you to information regarding each type of NCCI edit in the tables. That's where I downloaded the tables from earlier. So before we go out to the website, there are some additional resources that I thought would be helpful. I personally like the Medicare Learning Network because I feel that they do a good job of taking Medicare policies and putting them in a format that explain what needs to be done. It's kind of easier to read to me than the actual like change requests and things like that. CMS has also created a few booklets to help. They include topics on how to use the NCCI tools. There's proper use of modifiers 59, XE, XP, XS, and XU. And there's also one on global surgery. It contains a whole section on coding and billing guidelines. I also wanted to include links to some of our Encore presentations. As you can see, WPS has held a few webinars on the different aspects of the NCCI edits. Our Modifier Monday Encore covered a variety of modifiers that could be used, but we also held a webinar specifically on global surgery modifiers. So I just wanted to make you aware of those. I do want to go out now to the NCCI This is the landing page for the NCCI Edits. I did want to point out that there is contact information. I had put the email on the slide, but it's also linked here, so you can use that. The email address listed here is for general questions and concerns. Anything that is claim specific is going to need to be sent to the MAC who processed the claim. There's also information about submitting an appeal, and so it gives you a link to the appeals website so that it gives you additional information on how to do that. I want to go back up. I apologize for the scrolling here. I do want to call your attention to the Medicare NCCI Policy Manual. This manual explains the NCCI edits, the rationales for it. If we go into Chapter 1, we're right in the middle of it, but this does, like there was a question about mutually exclusive procedures. So this kind of goes in and it talks about, gives a little explanation of mutually exclusive procedures, why they can't be reported together, things like that. If we go back up to the top, there's a whole section on modifiers and modifier indicators. So it does go through the different modifiers that can be used. It goes into detail about each of the modifiers. So that's something that could be really helpful if you're trying to determine what you should be putting on your claim. If I scroll back up here, I'll go back. The Medicare NCCI FAQ library. This is broken down into sections here at the top. So if you'd like to jump to a particular topic, there's also a ton of resources within this with additional information. So if you had a question about medically unlikely edits, it kind of provides you some questions and answers where to find the information. This was something else that I thought was extremely helpful. While we're out here, I do want to take a look at one of the questions I got during the registration process. I'm going to go back up to the top here so you can see what I selected. The question I got was, what steps can we take if a managed care plan is not following NCCI edits? So there was actually a question related to it here in the FAQs. If I go to the billing and coding, in here in question 2, it asks about commercial payers denying payment, citing NCCI edits. Now, I don't know exactly what the situation was, but here it explains that CMS developed NCCI edits for Medicare and Medicaid fee-for-service programs. So they really do not have any control over how edits are used by private insurers. Now, Medicare Advantage should kind of be applying the same principles as fee-for-service Medicare, but again, those are private insurance companies. Before I check in with Ashley to see if we've gotten any questions during the registration, there was one other question that I got. I was asked, does Medicare Advantage plans have to follow CMS policy? And in general, yes. But Medicare Advantage plans are through private insurance companies, so there are some differences. For example, Medicare Advantage plans must cover all medically necessary services that original Medicare covers, but they may also offer extra benefits that original Medicare doesn't cover. They may also use their own coverage criteria to determine if a service is medically necessary or not. There could be services or supplies that original Medicare will cover without prior authorization, but a Medicare Advantage plan may require that you get approval for the same service. Medicare.gov does have a booklet titled Understanding Medicare Advantage Plans. While it is geared towards beneficiaries, there was some information that I found useful. I am going to have Ashley add that in the chat, but I just wanted to show you. There was, again, pardon the scrolling. It does talk about the differences between the Medicare Advantage plans. Sorry, that's about cost. So here's where it kind of was talking about how original Medicare maybe doesn't require prior authorization, but a Medicare Advantage plan would. So this may be something that, even though, like I said, it is geared towards beneficiaries, I know that providers have a lot of questions from Medicare Advantage plans, and it seems like there's maybe not a lot of resources for you guys. And since we handle original Medicare and those Medicare Advantage plans are through private insurance companies, sometimes it's hard for us to try to find you guys help. So I did want to let you know about this just in case you could find some information that would be useful. So now I am going to turn it over to Ashley and ask if we have had any questions come through in the chat.
Hi, Karen. We've just had one question come through in the chat, which is, please clarify separate practitioner versus same provider definition. Previous training info says same provider as two different providers working in same practice, billing under same group NPI. How is separate provider defined? Are the two separate provider and same provider now considered the same?
I'm sorry, I was talking on mute there. Before I answer that question, you said that it was training that we provided, I believe. Is that correct, Ashley?
It doesn't specify. It does say previous trainings.
Okay. I would like to go back and see what education has been held by other team members, and I see yes, WPS. Okay. I would like to go back and clarify what was said, and then we can move forward from there. I will get an answer for you, and I will send that out in an email. I just wanted, there was a lot of information in that question, so I just want to make sure that I cover all the bases and I get you exactly what you're looking for. So I apologize that I can't answer that right away, but I want to make sure that you get the right answer.
All right, and we do not have any additional questions in the chat.
Okay, great. I will move ahead then. Now, after the close of today's webinar, you will receive a thank you for attending email. Here is where you are going to find your certificate of achievement and the contact hours for continuing education units. This email also contains a link which gives you another opportunity to provide feedback. If you don't get this email, please check your spam or your junk folder. You'll also need to add messenger@webex.com to your safe sender list, and that will allow you to avoid any issues in the future. Now, if you joined only by phone, you're not going to receive this email. So if that's the case, please send an email to the education mailbox, include your name and the phone number that you used to join, and that way we can get a certificate sent out to you. Now, if you do think of any questions after this webinar, you do have 7 days to send those in. You can email those to the education mailbox shown here on the screen. Be sure to put today's topic in the subject line so that staff know that your question is related to this webinar and they will send it directly to me. Remember, if the question is claim specific, we ask that those do go to customer service. We don't have access to the system, and they'll be able to provide you an answer based on how your claim processed. When you disconnect from the webinar, you will be redirected to a CMS survey. I'm also going to have Ashley add a link into the chat. Your feedback really does mean a lot to us. We review what you have to say, and we really do our best to make the changes that you ask for. And this is also an opportunity for you to let us know what topics you'd like to see us provide education on in the future. So if you have a specific topic that you'd like us to educate on, please add that, and we'll get that put into our schedule. Also, if you have ideas that you think would improve how you receive your education, be sure to tell us that too. You know, we're really open to whatever ideas that you guys may have. The redirect is going to look like what you see here at the bottom of the screen. We don't have any control over how this appears, so we just want you to know that it's not spam, it's nothing malicious. If you click continue, it will just take you to the survey. That brings us to the end of today's presentation. On behalf of myself, Ashley, and the Provider Outreach and Education team, I'd like to thank you for being here today, and I hope that you will join us for future events. You may now disconnect.